Hello, I'm Dr. Ibrahim Elsharkawi, Assistant Professor of Medical Genetics at the Icahn School of Medicine at Mount Sinai in New York. Welcome to this chapter titled Fundamentals of Acute Intermittent Porphyria. Joining me today is our patient advocate, Nicole, who will share her experience living with AIP. Welcome, Nicole. Let's begin with a brief introduction on acute intermittent porphyria, or AIP. The process of making heme involves 8 enzymatic steps. And having a genetic deficiency in any one of these enzymes can lead to porphyria. So they're mostly inherited, they're mostly genetic, but there are definitely impacts and effects of drugs, nutrition, alcohol, and other genetic factors that go into play here. The symptoms are often due to effects of ALA or porphyrin accumulation. So we classify porphyrias in different ways. We can classify them clinically depending on whether features are mostly urological or cutaneous, or we can classify them based on where the enzymatic defect takes place. The acute porphyrias include acute intermittent porphyria, which we're talking about today, hereditary coproporphyria, variegate porphyria, and ALA dehydratase deficiency porphyria. The cutaneous porphyrias include porphyria cutanea tarda, PCT, congenital erythropoietic porphyria, CEP, erythropoietic protoporphyria, EPP, and X-linked erythria, XLP. And the most common types of porphyrias are AIP, PCT, and EPP. So AIP has an estimated prevalence of about 1 in 1,700 people, so relatively common in the world of rare disease. But penetrance in the general population is low. It's about 1%. So what that means is even if you have the genetic variant, what we call a mutation or a variant that causes disease, only 1% of people with a true pathogenic variant will exhibit or show signs of disease in their lifetime. And we don't quite understand why this is, but it's important to keep in mind that if you're thinking about porphyria in a patient, the absence of a family history does not rule out porphyria. Because you can have the mutation and not show signs of the disease in the same family. The prevalence of symptomatic disease is approximately 1 in 2 in 100,000 people, and women tend to be more affected than men. AIP attacks are often misdiagnosed. It confuses the process of disease identification and delays arriving at a diagnosis and delays their care. Nicole, can you tell us a bit about your journey? How and when were you diagnosed with AIP?
I was diagnosed with AIP over 12 years after I started having symptoms. Before porphyria, I was an honors student, a world-class athlete. I was a pilot. After college, I started a successful business and life was good. Everything was kind of going as I planned and I was happy. Then all of a sudden, out of the blue, I just became a shadow of my former self. I had always been able to push through things in the past, but this was it just knocked me out and there was nothing I could do. The first time it happened, I was walking my dog, just walking down the street like nothing's wrong. And out of the blue, this pain just came out like lightning and stabbed me in the stomach and knocked me to the ground. I could hardly move. I was able to crawl to the side of the road, and I was in a field and I'm laying there looking up at the sky and I'm thinking, this is it. I'm dying. I had gone through a lot of pain when I was an athlete falling down. So I have a high pain tolerance and I really thought that was it. I continued to have attacks. I had abdominal pain, nausea, vomiting, constipation, back and neck pain, chest pain. I felt like I was getting stabbed in the chest and I couldn't breathe. I had hallucinations. I had weakness and actually paralysis even, and just general brain fog. I almost died 3 times and I was in a wheelchair for 2 years. I saw a lot of doctors. I saw gynecologists, gastroenterologists, neurologists, pulmonologists, endocrinologists, pain specialists, cardiologists, just trying to figure this out. My parents were big advocates for me and helping me because I really was out of it a lot of the time and couldn't advocate for myself. During the course of seeing all the specialists, I had 9 abdominal surgeries trying to figure out what this horrible pain was. That was my worst symptom, including a hysterectomy that I did not need. And I really wanted to have children. So that was very hard for me, and it was devastating at the time. I was worried about the use of pain meds when we couldn't find the cause of the pain. And like I said, this went on for over 12 years, in and out of ER and hospitals. And one doctor even told me I just have to accept that I'm going to be like this for the rest of my life. And I thought, if we don't know what it is, how do we know there's no hope that I can get better? Finally, a doctor suspected porphyria and basically did a urine test, and it came back positive. And I was very hopeful. He said there were treatments that can help with it, and that I could get better. And I was really excited to hear that. But I was also skeptical because I had been told over the course of these 12 years, many things that they found that this is why you're having these symptoms. And we'd be like, all right. And then we'd do the treatment, and nothing really changed, all the surgeries I went through. So after about a month of treatment, I could actually think properly. I actually walked into the doctor's office. Over the years, I was able to get back to a normal life. I could look back every year and think, oh, this is better, this is better, this is better. And now I get to work full time. I do have a tax still, and I do still get treatment, but it's managed by my medical team.
Thank you for sharing that, Nicole. How did diagnostic delays impact your quality of life and emotional health as a patient going through that journey?
Well, at the beginning, I had to give up my business because I couldn't do it. I had to either choose that or, staying alive. It was literally that bad. That made me feel like a failure, and that was very painful. The pain was horrible. It really wears on you when it's just all the time. It's hard to stay positive. I lost not only my business, but I lost my mobility. I needed to ask for help a lot of the time, and that was hard for someone who doesn't like to ask for help, but I needed it, and I did get it. My family was wonderful. Whatever I was doing was very hard to follow conversations and think properly. I had always thought that being in a wheelchair was the worst thing, but the worst thing was actually not being able to think. And the other thing that was very hard is I became a very unreliable person. I was always going to family gatherings before, and now I never knew, because this is intermittent. Sometimes you're feeling better, and sometimes you're just in excruciating pain and you can't move. My family was there for me. They loved me. But after years and years and years with no answers, I felt that my family or friends were getting mad that I wouldn't show up to things. They would tell me, you just don't want to come. And it was the farthest thing from the truth, because that's what I needed the most at that time, was to be around my loved ones to support me. So I felt very isolated.
I can't imagine having to go through all that. Nicole, thank you for talking about it so candidly. So when we're thinking now about your quality of life and the emotional health aspects, can you talk a little bit about any advocacy or resources you found helpful in your journey?
Well, the biggest resource for me once I got diagnosed was the American Porphyria Foundation. They had so many stories of other members, and specifically the founder of the organization had written a book. And that's the first thing I got. I was diagnosed in 2006, and the internet wasn't what it was today. So I ordered a book and I read it. And I remember thinking this instant connection. And I thought, this is exactly what I went through. Immediately, I just felt less alone. And through the American Porphyria Foundation, I read other people's stories, and then over the years, I met other patients, and that was very healing, having that connection. After feeling like I was in the dark for so many years and alone, I just felt like I was back into the light, and it was very helpful.
Thank you. I think one thing that often might not occur to us as clinicians is having a diagnosis can open the gateway to community and connection with other patients with the same diagnosis in the world of rare disease. What about treatment options? Were there helpful things clinicians said or did to explain treatment?
Yes. The treatment that I had needed a port at first to make sure that it was going to work, and I didn't have surgery right away. We did it peripherally, and I had a hard time with that, a lot of phlebitis, and my veins all just kind of exploded, but we couldn't use them anymore, and I had a lot of reactions. So they explained I needed to have pre-medication, and actually I ended up getting a port, which made it much easier. And they just explained to me that the frequency of treatment is going to be possibly inconsistent, because this is intermittent, and they just were very supportive in listening to what I was feeling during these attacks and trying to figure out how many treatments I needed and how far apart to get me, back on my feet and out of the hospital. It was hard, but having them explain that to me helped a lot.
Nicole, thank you for talking about it so candidly. So, what are the major clinical features of acute porphyrias? So, the clinical features arise from accumulation of the porphyria precursors, the porphyrins, and then dysfunction and death of neurons is involved in the pathogenesis of this disease. So there are overlapping clinical syndromes here. So during acute attacks, patients are in a lot of pain. It's a pain crisis. And autonomic disturbances can also occur. So you're thinking of a patient who may present like acute abdomen, but doesn't have peritoneal signs on exam or doesn't have any signs of acute abdomen on cross-sectional imaging. Peripheral sensory or motor neuropathy can be present. Progression to truncal and global and CNS dysfunction is often seen. Sometimes we can see seizures. And on the background of this is subacute or chronic pain and paresthesias. The signs and symptoms of an AIP are broad. So the most common one, like we just talked about, is severe abdominal pain. These patients are in a great deal of pain. Tachycardia, dark urine, motor neuropathy, constipation, nausea, vomiting, mental status changes, cognitive effects, systemic hypertension, absent reflexes on exam, back pain, sensory neuropathy, postural hypotension, convulsions and seizures, chest pain, and even coma. So lab features during acute attacks can be often unremarkable, but there may be a few clues here and there. So your CBC, your complete blood counts can be normal, but your white count may be a little high or low. You may also get a little bit of anemia, a little bit of reduced hemoglobin. Your routine liver function tests are normal. And then hyponatremia, low sodium, or hypomagnesemia can occur. And those will be a little bit of context clues, things to pay attention to, although, of course, they're not specific. What you really want to test for and what you really want to see to arrive at a diagnosis, and these labs are best drawn during an acute attack, are your urine ALA and PBG and uroporphyrin. So these are special tests you can send collected in urine in a spot urine sample. And if they're elevated, and the most accurate way to determine this is during an acute attack, because they can be normal in between acute attacks, especially in folks who don't have frequent recurrent attacks. Consider AIP in all teens and adults. We say generally between the age of 15 and 50, although of course there are exceptions, with unexplained symptoms, and especially women who have reached menarche, people with recurrent abdominal pain that is not explained by your conventional first-line tests and imaging, muscle weakness, myopathy, hyponatremia, dark or reddish urine. And you can establish the diagnosis biochemically rapidly by a qualitative test for PBG in single fluid urine. So what we want to do is collect the PBG, ALA, and they'll do a creatinine in a random spot urine sample. Genetic testing, we live now in the age, thankfully, of genetic testing, molecular testing, where we can sequence your DNA and find mutations, otherwise known as variants, in certain genes that would disrupt function of the gene somehow and lead to disease. So in acute intermittent porphyria, this is HMBS is the name of the gene and the enzyme that is dysfunctional in AIP, or PBGD. Genetic testing helps confirm or exclude a diagnosis, and it's about 95% sensitive and 99% specific. So genetic testing is now preferred as over measuring the activity of the enzyme levels in RBCs, which is how we used to do it before the advent of the technologies that we have now that allow us to look at DNA a lot more accurately. And also results of RBC enzyme testing are normal in about 5% of patients with AIP, so just something to keep in mind. So what are the key takeaways here? So Nicole, what would you say to clinicians like me who like to learn more about how we can best serve you?
Well, porphyria is called the little imitator because many of the symptoms look like common disorders. Clinicians will think of the more common things to test for. And what I would say is when those tests come back negative, just think porphyria. As Dr. Elsharkawi said, there are tests available. It's pretty easy to test. So it's really just keeping it top of mind. Think porphyria and just test for it.
Absolutely. Thank you, Nicole. So the key takeaways here are if you're seeing a patient that's in a lot of pain, that appears really sick, where the pain may be recurrent but doesn't have to be, where family history may not be present, and you can't explain what's going on, your first line testing that you would get in an ER or in the wards or in the ICU are just not giving you an answer. Think porphyria, think rare disease, think something that you have to specifically test for to arrive at a diagnosis. And remember that while this disease can occur in both men and women, it is more common in women, especially women of childbearing age. And we often have subconscious biases and tendencies to diminish recurrent abdominal pain in women where we can't find an explanation. And this is definitely... Nicole, thank you for this great discussion and for sharing your journey with us. And thank you all for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.